Hi everyone and welcome to Module 5. This is going to be our last week that we focus on carbohydrates, and we have a couple of fun topics. First we're going to talk about fiber, and then we're going to talk about a disease that is highly relevant when we talk about carbohydrates, which is diabetes. So first we're going to talk about some of the different types of fiber and give examples. Then we're going to talk in depth about the main characteristics of fiber and the health effects that are imparted by fiber. Okay, so the IOM tells us that our total fiber intake consists of fiber that we get directly from the diet where it's naturally occurring, and then we also consume functional fiber. And you can think of functional fiber as kind of isolated or manufactured fiber, where just that specific component of the food is either extracted from its original source or it's manufactured and then added to a different food because we know it has beneficial physiological effects. So here's a list of our dietary fibers and our functional fibers, and you can see that there's a lot of overlap between the two because some of our fibers that we find in the diet, like cellulose, we know have positive health impacts, so manufacturers will isolate that and add it to other foods as a functional fiber. Okay, so we have cellulose, which we know is the main component of plant cell walls, and we can see that it has beta-1,4 glycosidic linkages, which we know means that we cannot break it down with our endogenous enzymes, and instead we need our bacteria in our colon to break it down for us. And cellulose is an insoluble fiber. So we'll talk about one of the characteristics of fiber is if it's soluble or insoluble in water. And most of our insoluble fibers you can kind of think of as like roughage, like broccoli, cabbage, green beans. Then we have our hemicelluloses that are also found in plant cell walls, and these are also insoluble fibers. We have our pectins, which we know for anybody who's made jam, we add the pectin. And after you have your kind of watery mashed up fruit, you can add pectin and it will gelatinize. And that is due to its water holding capacity that we're going to talk about. But this pectin, you do buy it in the store, but it's extracted from foods in that way because we naturally find it in apples and strawberries and other fruits and vegetables. We have lignin, which is found in cell walls of woody plants and seeds. So think carrots, radishes, eggplant, green beans. And lignin is of particular research interest because we know it to have both carcinogenic and anti-carcinogenic effects. Then we have our gums, which are typically added. We do find them in nature or naturally occurring in foods, such as like oatmeal. So if you think about it, when you cook up oatmeal, it has that kind of gummy consistency, and that's really what the gums are. And if you look at ingredient lists, especially of processed foods, you'll see that gums are added, gum arabic, guar gum, that these are added to foods because of their desirable thickening properties. And these are soluble fibers. So whenever you think of that kind of viscous, thick gumminess, a lot of times it'll be a soluble fiber. Then we have beta-glucans, which are used typically as a functional fiber, and we can see by the bonds beta-1,3 and beta-1,4 that we're not able to degrade these with our own enzymes, so that they need to be fermented in the colon, and these are highly fermentable. And because of the health effects of this fermentation, we add these often as functional fiber to foods. And we're going to talk about how these health effects from fiber come about, or what the mechanisms are. Then we have our inulin, oligofructose, and fructooligosaccharides. So oligofructose, when we see it in the diet, it's usually added to cereals, yogurt, dairy products, frozen desserts. And inulin actually has a really special function in the clinical setting because it's not reabsorbed, and it passes freely through our glomerular membranes, so that we can use it to test kidney function. So the inulin would be infused into the blood at a constant rate, and then we can measure output in the urine to determine how well our kidneys are functioning. And then we have chitin and chitosan, which are used as functional fibers and extracted from crustacean exoskeletons. And like we talked about the first week, we also have resistant starches, which typically means that the starch is in there and we might be able to digest it, but it's sequestered in a plant cell wall so that we can't get to it. We don't have the ability to access those carbohydrates. So they could be naturally occurring, or we could get them from food processing. And we also have our polydextrose and polyols, which are often bulking agents or sugar substitutes. We have psyllium. If you've heard of psyllium seed, that's often used as a functional fiber because of its laxative properties. It's a bulking agent, and it decreases transit time through the intestines, so it can help with constipation. And then we have our resistant dextrins, which occur when we with food processing. So you can see we have tons of different kinds of fibers. And when we eat a food, keep in mind that there's not usually just one type of fiber in a food. It's usually a mix so that we can get benefits from all different benefits from these different types of fibers that we can consume. So here are the guidelines from the Dietary Guidelines for 2015. And our goal really with our clients is to introduce at least 14 grams of a mix of different fibers per 1,000 calories that are consumed. So you can judge that based on how much the person is eating. And we can see that for women, our recommendations are about 25 grams, and for men, it's more 30 to 35 grams, just because they eat more food typically. So we have four main characteristics that we're going to discuss of fibers, and some of them are overlapping. So number 1 and number 2 overlap quite a bit. Number 1 is solubility in water. Number 2 is water holding capacity and viscosity. 3 is adsorption capacity, and 4 is fermentability. And we're going to talk about each of those and how they contribute to health benefits of fiber. So a water-soluble fiber is water-soluble. It dissolves in hot water, whereas a water-insoluble fiber does not dissolve in hot water. And here are our examples. And you can see for the water-soluble fibers, it would be kind of what we think of, these pectins and these gums that are kind of goopy or viscous. And when we make this kind of, this viscosity actually has to do a lot with its water holding capacity, but solubility in water and water holding capacity, there's a lot of overlapping, even if they are can be exclusive too. But for the most part, when we have fibers that are soluble in water, it's actually going to slow down our gastric emptying, okay? And we'll talk about this more with number 2. Slow down our gastric emptying. It's going to make everything go slower through our intestines, so it's going to increase transit time. It's going to make it go slower. And you would think that if it's going to make it go slower, then it would increase nutrient absorption, but it is not the case, because when it's in this kind of thick, viscous mush, I guess I should say, then it's making it harder for the enzymes to come in contact with the nutrients. So we're actually going to have decreased nutrient absorption, and we'll talk about that more. But for our water insoluble fibers, that is our fibers that don't dissolve in hot water, they are actually going to decrease transit time. They're going to speed up everything through our intestines. And if you think about it, that makes sense. That's our roughage, our broccoli, and our Brussels sprouts. And and the water insoluble fibers are also going to increase fecal bulk. So that's good for people with constipation. So our second characteristic is water holding capacity and viscosity. And as I said, there's a lot of overlap between water holding capacity and viscosity and water solubility. But not only water soluble fibers have high water holding capacity. It depends on the pH, where you are in the GI system. It depends on the size of the fiber particles or an extent of processing. So for instance, like coarse bran has a higher water holding capacity than fine bran. Whereas the fine bran, which increases fecal bulk and transit time. So when we like maintain the integrity of the grain, it has more water holding capacity. So you can kind of think of fiber that has a high water holding capacity as like a dry sponge. And as it goes through your digestive tract, it's going to kind of soak up all of the fluids that are around it. And as I said, usually water holding usually fibers that are water soluble do have a high water holding capacity. Okay, so for these fibers, so again, you think of it as a dry sponge, small when it starts out, and then it's going to kind of hold all this water, and get bigger and bigger and bigger. Okay, so because we have kind of this like thickened, let's call it chyme, but think about your food all mixed up and mixed with the digestive juices. So let's call it chyme for now. Um, when you think about when this gets really kind of thickened and it gets bulkier and bigger, it's going to kind of because of its viscosity, is going to move much slower through the digestive system. So it's going to leave our stomach slower and go into the duodenum slower. And the benefit that this can have is that it can this delayed gastric emptying can make us feel more full. And so it can decrease intake overall. Now, as this viscous kind of mishmash is moving slowly through our GI tract, again, we are actually counterintuitively going to have reduced mixing with the GI contents. So we kind of have this like thin layer of water that lays on top of our endothelial lining. And when we have this like big viscous goop that's going through our GI system, it doesn't give the opportunity for these enzymes on the brush border to interact with this goop, really, with our nutrients in it. So we have reduced mixing of the enzymes with the GI contents. And because of that, we actually have decreased nutrient absorption, so not as much is going to be absorbed in the first place, and also what is absorbed is going to do it slower. So if we think about glucose, for instance, we would absorb less of our glucose, but the glucose that we do absorb is going to be absorbed slower. So if you think about how our blood glucose rises after a meal, it would be a much slower rise in blood glucose if our meal contains some of this fiber that has a high water holding capacity and high viscosity. Okay, and we do see that our fibers with high water holding capacity do have these effects. So gums, pectins, and beta glucans and psyllium have been shown to slow transit movement, delay glucose absorption, lower glucose concentrations, and consequently impact the insulin response. And if we go through all of these and then think back to the last slide too, where we're delaying gastric emptying, so we're increasing satiety, all of these impacts are beneficial to the people with diabetes. So they're going to have, if they include these types of fiber in their diet, they'll have reduced postprandial blood glucose and therefore a reduced need for exogenous insulin. And we'll also see why it can decrease cholesterol. Okay, our third characteristic is adsorption or binding capacity. So we're used to thinking of absorption as like a cell would absorb a substrate, but this adsorption means this that this molecule, this fiber molecule, is binding. Think of adsorption as binding. So some of our fibers, gum, pectin, hemicellulose, our soluble fibers, actually have the ability to bind to substances in the GI tract. And its ability to bind, again, depends on the pH in the GI tract, the particle size, food processing, and fermentability. Okay, so adsorption capacity is associated with physiological effects in the GI tract, and we'll talk about why. But it is associated with diminished absorption of lipids, increased bile acid excretion, lower blood cholesterol, and altered mineral balance. Okay, so we know that some of our fibers can actually bind to fatty acids, cholesterol, and bile acid in our GI tract. So we've eaten our food, it's in our digestive tract, it's in our intestines, and we have our fibers in there that will actually bind to these substances. Now, when fatty acids and cholesterol from our diet bind to this fiber, they're not going to be absorbed. They can't be absorbed into the enterocyte. They can't form the micelles to be distributed to the rest of the body. So what's going to happen? They're going to keep going to the large intestine for excretion or degradation by bacteria. Also, when the fiber binds to the bile acid, it's just what it would seem like would happen. It can't be reabsorbed. So our body typically reabsorbs the bile acid that we make. It's highly efficient. But when the fiber binds to the bile acid, it cannot be reabsorbed, and therefore it gets excreted or degraded by intestinal bacteria. Now, consumption of fibers with high binding capacity also can lower blood cholesterol, and it's for the reasons that we just talked about. So the first is that it's going to, just like we talked about, it's going to increase excretion of bile acids. So then less bile acid is going to undergo intrahepatic circulation, and we'll talk more about these processes in the lipid section. But basically, then we need to use the cholesterol that we have in order to make new bile because we excreted more in our feces because of our fiber intake. And when we use up the cholesterol that's in our body, then it leads to lower serum cholesterol. And as we all know, decreasing our serum cholesterol is a good thing because it's going to prevent this buildup of these atherosclerotic plaques that are associated with heart disease. So also though, fibers with a high binding capacity can lower cholesterol through a second mechanism. So what it actually will do is shift the bile acid pools from one kind of bile acids called cholic acid toward another type of bile acids called chenodeoxycholic acid. And this chenodeoxycholic acid is a very special kind of bile acid because it actually inhibits our key enzyme that we need to make cholesterol. So if that enzyme is inhibited, we'll make less endogenous cholesterol, and therefore that will contribute to lower blood cholesterol. And we see that indeed some of our fibers like oat bran and soybean fiber have been shown to decrease serum cholesterol. And then our fourth characteristic is altered mineral balance, and you don't have to worry too much about this one, but basically know that depending on how quickly the fibers ferment by the bacteria in the colon, these types of fibers can either have a positive or negative impact on your mineral balance. So, for instance, when we have slowly fermentable fibers, it actually can result in increased binding of the minerals, and therefore we lose more minerals from the body. However, if we have a rapidly fermenting fiber, it can actually have a positive impact on mineral balance because then those minerals can be released and absorbed into the colon. And also, when we have this fermentability happening in the colon, that it actually increases the acidity of the environment, and then that can increase mineral solubility. Okay, so let's talk about our fourth characteristic, which is degradability or fermentability. So first I'm going to talk about fermentable fibers, and then I'll talk about the non-fermentable ones. So when our fiber ferments in our large intestine, the primary products are lactate and short-chain fatty acids. So we talked about lactate last week in our metabolism lecture, and also short-chain fatty acids. So these are primarily acetic, butyric, and propionic acid. We'll talk about more about those in the lipid section. But as we know from our discussion about FODMAPs and lactose intolerance, we also have other products from fermentation in the colon, such as hydrogen gas and methane gas. Okay. So these short chain fatty acids are actually a pretty active type of molecule and have physiological effects. So rapid absorption of short chain fatty acid in the large intestine stimulates rapid water and sodium absorption in the colon. It also increases mucosal cell proliferation. Short chain fatty acids can be used for energy, just like any other type of fatty acid. So depending on what type of fatty acid, they could be used for energy in the epithelial cells. They could be go back to the liver and the portal vein and be metabolized, or they can be go to other parts of the body and be used for energy. And then fourth, short chain fatty acids, as I had said before, increase the acidification of the environment in your colon. And that can result in less solubility of bile, so more bile excretion. And also, calcium in our intestine then becomes more available to bind to bile in fatty acids, which we see can be protective against cancer. Okay, our non-fermentable fibers are more slowly fermenting in our colon. And these are particularly valuable in promoting microbial proliferation in the colon. So the more we know, the more we realize how important our microbiome is in our colon toward our health, and how having a healthy balance supports overall health and a lot of specific health outcomes. So when we have these slowly fermenting fibers, this really helps to promote this proliferation of the microbiome. And this is really important for a couple of reasons. Number one, it can help detoxify any toxins that we've taken in. So if I eat something that's somewhat toxic, and it goes into my colon, well, if I don't have a good microbial environment, then I'm exposing my intestinal cells to this toxin. But if I have a really good microbial environment, then they're going to kind of scavenge and sequester these substances, and then I'm going to excrete them, and I'll have less exposure to that toxin. Microbial proliferation is also important for increasing fecal volume, and when someone is constipated, that a lot of times can stimulate them to have a bowel movement. Okay, so let's look at these specific, with what we just learned about the different characteristics and health outcomes of fiber, let's look at some specific health problems. Okay, so for cardiovascular disease, we do see that soluble fiber is beneficial because it has these characteristics of lowering blood cholesterol by slowing the absorption of cholesterol and binding to bile, so that we need to use up some of our cholesterol to make more bile. In diabetes mellitus, we gave the whole list of why soluble fiber would be improved there, but it will delay gastric emptying, so it'll keep the person more satiated. It's going to slow transit time, so it's going to decrease in slow absorption of glucose and subsequently insulin secretion, and this can lead to improved insulin sensitivity. For those who are obese or are seeking weight control, both insoluble and soluble fibers are beneficial. So first, the higher value. So of course it does promote satiety when we have this gastric emptying. But I think for all of these conditions, it's important to keep in mind what foods have high fiber. They're usually foods that have low energy density but high nutrient density. So in general, this is just consuming these types of foods is going to promote health. Okay. And then for a number of gastrointestinal disorders, insoluble fiber can be beneficial because it can increase bulk, increase intestinal motility, and protect against prolonged exposure to toxins because it helps speed transit time through the intestines. Okay, so we talked about some of the reasons why consuming fiber can help to lower blood cholesterol, but let's go through this one more time in kind of a different format here. So we see that cholesterol delays gastric emptying, okay? And when we delay gastric emptying, then we're, I guess you could just say delay or increase transit time in general. Do I have that on there? Okay, you can put increased transit time, because what's going to happen with that is that we're going to have slower glucose absorption, and if we have slower glucose absorption, and we're going to have slower lipoprotein formation, and we all know that lipoproteins are like our LDL cholesterol, for instance, so that can help be beneficial for lowering cholesterol. If I don't have as high of glucose, I'm not going to have as high of insulin secretion and lipoprotein formation. Also, we know that intake of fiber causes this kind of, with certain fibers, causes this kind of viscous substance, and that's going to impair the mixing of enzymes with the nutrients, so we'll have decreased nutrient absorption. It also will bind to bile acids and cholesterol and fatty acids, which is going to interfere with micelle formation, and then therefore, of course, we have decreased absorption of the cholesterol, and that can help us lower our serum cholesterol. We also have interference of mixing with intestinal contents. That's kind of the same as interference with digestive enzymes. And then we have inhibition of cholesterol synthesis. So as we talked about, one of the products of fermentation is short chain fatty acids, and that can result in a bile acid that inhibits the enzyme that we need for cholesterol biosynthesis. Okay, so here's a nice kind of overall graphic here. So it shows on the left, you can start with soluble or insoluble fibers. So let's start with insoluble just because it seems a little easier. So first we look at water holding capacity, and we know that it increases fecal volume, decreases colonic transit time, increases frequency of defecation. We also know that insoluble fibers can be slowly fermenting, and that can lead to first it can lead to microbial proliferation, but it can also increase our production of short chain fatty acids by the microbiome, and so that can lead to mucosal cell proliferation, and it can also provide us with energy. Let's look at the soluble fibers. Again, these can have a high water holding capacity, and those that do have increased fecal volume, but they also can form this gel, and that can actually decrease the rate of gastric emptying and increase transit time, or make it slower, and it cause increased or decreased nutrient absorption, including of glucose. Soluble fibers also have a high adsorption properties, so that, as we said, can lead to altered mineral balance and can lead to more excretion of bile acids, lower lipid absorption, and lower serum cholesterol. So this is kind of a nice overview. Okay, and I'll let you do those questions on your own. And now we're going to go to the second part of the lecture, which is about diabetes. Okay, so our learning objectives for this part are to understand diagnosis and screening recommendations of diabetes, and I'll go through those parts pretty quickly because I think they're a review, but I just think it would be helpful to kind of mention them in this context so that we can kind of all be on the same page. We're going to talk about the different forms of diabetes, macronutrient metabolism in diabetes, and the complications of diabetes, and we're also going to discuss glycemic index. Okay, so there's can be different forms of diabetes, but they're all characterized by altered blood glucose regulation, resulting from defects in insulin secretion or sensitivity, or both. And because we have defects in insulin secretion and how our insulin functions and how we respond to our insulin, then that can result in chronic hyperglycemia, which can lead to long-term damage that we'll talk about in detail. So we know that according to the CDC, we actually have over 29 million people, or about over 9% in the US, that have diabetes. Most of them are diagnosed, but a large number are not. And we see that our rates are much higher in minorities compared to the white population. And here are our criteria for diagnosing diabetes. So one of the parameters would be that the individual has a hemoglobin A1C of at least 6.5. I know this is all review for you. We can also measure fasting blood glucose. We can measure 2-hour postprandial blood glucose, and we can measure, or we can do just kind of a random measure of glucose. Okay, so we know that the A1C has the greatest convenience. We don't need to do really any special procedures, and it's also great because it measures the average blood glucose over a few months. The fasting blood glucose is, again, easy to administer. It's a low cost, but the patient does have to fast. The oral glucose tolerance test is where a person consumes or does, sorry, on fasting, after fasting, the person consumes a set amount of glucose, and then blood glucose samples are taken consequently and measured. And then we can also do a casual plasma blood glucose, especially when we have like other symptoms that make it seem like, okay, this probably is glucose. And that would just be taking it at any time without regard to when the person ate last. And so this would be something you would do, especially if you have combination with the symptoms, and we'll go through all of these symptoms. But the classic symptoms of diarrhea are polyuria, polydipsia, polyphagia, unexplained weight loss. Okay, so here are our parameters for how we diagnose diabetes. Here we have our normal reference ranges for each of the 3 tests, our pre-diabetes range, and then the cutoff points for which we consider the individual to have diabetes. Here are our screening recommendations. So for asymptomatic adults, so for asymptomatic results, we have a set of screening recommendations, especially for people who may be at higher risk. So they maybe have hypertension or high cholesterol, or a family history of diabetes or something like that. If they don't have these criteria, then the individual should begin testing regularly for diabetes at 45 years, and then every 3 years after that. And then for children who are asymptomatic, we do want to test them if they are overweight or if they have a family history or are at high risk for other reasons, and start that at age 10 years and screen every 3 years if they are at high risk. Okay, so we have a couple of main types of diabetes. We have idiopathic and secondary. So normally when we think of diabetes, we think of idiopathic, type 1 or type 2 diabetes. However, we can also get a secondary type of diabetes and secondary means that the diabetes is secondary to some other reason. So I could have an endocrine disease. I could be taking medication that's causing diabetes. I could have diabetes from my pregnancy, gestational diabetes. Okay, so our first type of diabetes is idiopathic type 1. We call this insulin-dependent diabetes, or they more used to, yeah, we would call it insulin-dependent because the person doesn't produce insulin. Although, of course, type 2 diabetics can also be dependent on insulin, too, if they have a severe case. This is defined by development of ketoacidosis in the absence of insulin therapy because the person doesn't have any insulin at all. It can't to oxidize, then it's got to depend on fat. So if someone had type 2, usually they would have some glucose, or this would be less severe, but because there's no glucose to oxidize, then the person has to rely on fat, leading to ketoacidosis. So for most people, we see this in childhood, and we don't typically associate it with overweight like we would type 2 diabetes. So this ketoacidosis is actually the main thing that's going to cause a lot of these classic type 1 diabetes symptoms. So the polyuria, polydipsia, nausea, weakness, shortness of breath, fruity breath, and confusion. All right, so we know that type 1 diabetes can be somewhat genetic, but we also know that there can be some environmental factors that might trigger type 1 diabetes. So one of these that's being considered is early introduction of cow's milk protein. So oh, sorry, of cow's milk. So not formula, but of cow's milk itself. And this could trigger an autoimmune response. It's thought that the antibodies that our body would make in response to these proteins that we have in the milk also may then recognize our beta cells as foreign as well and attack those. We also know that for a number of autoimmune diseases that they can be kind of activated, you could say, by other viruses. So, for instance, we know that fetal exposure during pregnancy to certain viruses has been associated with the child developing type 1 diabetes. And then we also know that we have higher risk of type 1 diabetes in environments that are colder. And I think this is the case with I've heard this about definitely with multiple sclerosis too. I'm not sure if it's necessarily the cold or, so I guess in this resource that I had, it said that it altered the body's metabolism and can increase the load on beta cells. I know with MS, the thought is that also that vitamin D could have an impact. So I'm not really sure if that would play into this conversation as well. And again, so all of these types of environmental factors, they'd probably only make a difference for someone who was, genetically vulnerable to it. Obviously not everyone who's living in cold weather is going to get type 1 diabetes, but it can increase risk. Okay, and then we have our classic type 2 diabetes, one of the diseases that's going to keep us all in business, unfortunately. We call it non-insulin dependent, but when people have severe forms, of course, they do depend on insulin, though they do have some circulating insulin. It might be very, very little, but they do have some, and they have the ability to make this insulin. So because they have some insulin, then the body is able to get some glucose into the cells and oxidize it. So we rarely, unless we have a very, very, very severe case, have to rely on fats for energy and ketoacidosis and all of those symptoms that go along with it. Okay, so again, this is hopefully a review for you, but as type 2 diabetes progresses, the pancreas does produce insulin, but then we become less and less sensitive to it. So because we're less sensitive to the insulin, the blood glucose cannot get into the cell. Remember, insulin is kind of our key to get our glucose into the cell. So our body's saying, okay, I'm starving, I'm not getting any glucose. So the pancreas says, hold on, I'm making more insulin, I'm making more insulin. And then what that does is basically exhaust your pancreas, and then the individual would have decreased ability to make insulin after that. And we know that type 2 diabetes is associated with adiposity and obesity and physical inactivity, but not always. We can't generalize that to every single individual. But unfortunately, when we have this type of process going on, what actually ends up happening is that we have increased body fat, and that can increase insulin resistance too. So we kind of have this like self-aggravating cycle. Okay, and then really quickly, I'm going to go through, we can also have secondary diabetes mellitus. So as a consequence of a gene mutation, as a consequence of pancreatic disease. So for instance, for pancreatitis or cystic fibrosis, it could have nothing to do with diabetes, but because we have damage to that area, then that can lead to diabetes. We can have endocrine disease, including certain hormones that can inhibit the action of insulin by producing other hormones that are counter-regulatory, such as epinephrine or growth hormone or cortisol. We can have drugs such as glucocorticoids that can interfere with insulin function, gestational diabetes, as I said, and then we can have other genetic syndromes that can lead to diabetes. So it's not, in all of these situations, diabetes is not the primary problem. It's, I guess you could say pregnancy is not really a problem, but there's a primary condition, and then diabetes is secondary to that. So, in uncontrolled insulin dependent diabetes, we have increased glucose output. So, that makes sense, right? So, our body's saying, I don't have enough glucose. Even if there's glucose in the bloodstream, it's not getting into the cells. So, our body's starving. So, basically, then the liver's like, make more glucose. So, it's going to mobilize the glycogen stores, it's going to make new glucose via gluconeogenesis. So it's going to increase our blood glucose, leading to hyperglycemia. Our hepatic, if we remember, so if we think about back to glucokinase and how it's regulated, we know it's regulated by insulin. So, if our insulin is not working right, then our glucokinase is not going to be working right. So then what happens? We have decreased phosphorylation in the hepatocytes. And what does the phosphorylation do? Remember, when getting from glucose to glucose 6-phosphate, phosphorylating that glucose first makes it active and also traps it in the cell. So if we have, we don't have appropriate insulin levels and we can't phosphorylate the glucose with glucokinase, then we're going to have increased glucose going into the blood because it can't be trapped in that cell. Okay. Insulin deficiency can also also impairs other tissues utilizing glucose. So we know that insulin stimulates glucose uptake in the skeletal muscle and adipose tissue. See what this says. Okay. Covered everything that I wanted to. Okay, so also we have the fact that we have hyperglycemia doesn't only impact, our liver and our skeletal muscles, it also impacts our kidneys because when our blood glucose level gets so high, it surpasses our kidneys' capacity to absorb the glucose, and therefore the glucose is going to go into our urine, and that's what we call glucosuria, and that's like a classic symptom of hyperglycemia. We also know that glucose is a diuretic because of the osmotic gradient. So if we have glucose in our kidneys and we can't absorb it, then it's going to be in our fluid. And because of the osmotic gradient, more water is going to come in to kind of dilute that glucose. And so that's going to lead to a lot of loss of fluid. So it can lead to dehydration and a lot of urination or polyuria. And because we're peeing so much out and we're getting dehydrated, it can lead to the symptom of polydipsia or needing to drink a lot, activated thirst mechanism. Okay, and then because our glucose isn't getting into our cells and we're losing more of it in our urine, then that is going to increase appetite and food intake, our classic symptom of polyphagia. Okay, so here we're going to talk about lipid metabolism in diabetes. So we'll go more over this in the lipid section, but I just want to kind of give an overview here because we are talking about diabetes. So briefly, if we don't have enough insulin so what does insulin do? It helps us store things, right? So it's going to help us store triglycerides. So if we don't have enough insulin, what is going to happen is we're going to not store these triglycerides. Instead, they're going to be left in our blood and we'll have hypertriglyceridemia. And then so in some cases, okay, so then these triglycerides are just kind of in our blood and they can be taken up by the liver or other tissues, not the brain, and metabolized for energy. But if we don't have enough glucose and we have all of these free fatty acids, then in our liver, the liver is going to say, okay, we're really running low on energy here. And what's going to happen is it's going to produce ketone bodies. And then these ketone bodies are going to leave the liver and they can be used for energy in different parts of the body. But just keep in mind that these do have some other negative physiological effects when we have ketoacidosis. So some ketone bodies are normal and absolutely fine. It's when we get these really, really, really high levels of ketone bodies that we get ketoacidosis. And in these severe cases where we have so little glucose and we're producing a lot of ketone bodies, then our brains can utilize these ketone bodies for energy. So these ketone bodies can actually be sensed. So in people who have high production of these ketones, we can see ketonuria, we can measure them in the urine, and we can also smell them on their breath. So if you've ever known a type 1 diabetic, a lot of times they'll say if they have like severe ketoacidosis, then you can actually smell their breath and it smells kind of fruity because it has that kind of fruity smell. Okay, so again, some ketones are fine. And a lot of people who don't have this type 1 diabetes are actually trying to use the keto diet for like as a therapeutic diet, and we'll talk more about that in the lipid section. But when we talk about type 1 diabetes, we are talking about severe ketoacidosis, okay? We're talking about like no glucose is available basically, and so we have to break down our fats for energy. And this so ketone bodies you can kind of think of as like a waste product from fat metabolism, but when we get too high of levels of these ketones, it can lead to symptoms such as shortness of breath, we'll talk about why, breath that smells fruity, nausea and vomiting, and dry mouth. Okay, so we talked about carbohydrate and lipid metabolism. Now let's talk about protein metabolism in diabetes. So again, all of these, it's not just carbohydrates that are regulated by insulin. All of our other macronutrients are too. So if we don't have enough insulin to kind of help us build up that or utilize our glucose, then what's going to happen is that we're going to rely on our proteins for gluconeogenesis, because our body is going to say, okay, even though we do have enough glucose, it's not getting into the cell, and the signals to our body is that we need to make more glucose. So our body proteins are going to be broken down for gluconeogenesis. And once we start breaking down these proteins, and remember, we're losing glucose in our urine, this is going to lead to weight loss, despite the fact that people who have type 1 diabetes may be eating all of the time. Our cells are hungry still, and so people still may be thin if they're type 1 diabetic. It can lead to weight loss. Okay, so let's talk about some of the complications of diabetes. So the first one is hypoglycemia, low blood glucose. Okay, so this can be caused by inadequate food intake. If the person is, especially if the person is taking insulin or diabetes medication, and so they have this kind of exogenous insulin coming in, but you're not eating enough food for the insulin to have an impact on, then you can kind of have this like, you can go too far with treating yourself for hyperglycemia and go into hypoglycemia. And so basically, when someone's taking in insulin, they really need to time it with their exercise and with their meal intake. And if they don't do that correctly, then they can result in hypoglycemia. Okay, and here are some of the early signs and symptoms of hypoglycemia: sweating, headache, hunger, weakness, poor coordination, numbing. So when it says, sorry, I never know how to say this, adrenergic responses, that means it's activated by adrenaline, such as epinephrine or norepinephrine. And these later neuroglycopenic responses, that means from the nerve cells. So think about lack of glucose to the nerve cells, lack of glucose to the brain will cause dizziness, confusion, irritability, shakiness, and up to a seizure. So here are our early signs, and here are our later signs and symptoms. And we can treat this pretty easily by giving a quick dose of carbohydrate. That will be quickly absorbed, I should say. Okay, and then we also have the complication that we think of the most, hyperglycemia. So this could be caused by excessive food intake, so really, really high glucose intake, also paired with inadequate insulin or hypoglycemic agents. So again, if you are taking an insulin or diabetes medication, we've really got to time this with our meals and with our exercise. High blood glucose can also be caused by stress or by certain medications. So pretty much anyone who's in the hospital is going to have high blood glucose because your body is under stress, and one of the like natural responses to that is to increase blood glucose. So if we have hyperglycemia, one of the consequences that could be in type 1 that we have ketoacidosis or DKA, diabetic ketoacidosis, which we just talked about. And in type 1 or type 2, we may not get all the way to ketoacidosis, but we could have hyperosmolar non ketotic syndrome. And so this is actually a serious condition that we most often see in older people, and it's usually brought on by some like external factors such as illness or infection or something like that. And then we do have, even if we don't have like advancement to this ketoacidosis, we still get some of these really severe symptoms such as polyuria, polydipsia, and so on. And if it goes too far, then it can lead to seizures and coma and eventually death. So we can have these severe symptoms in type 2, but it's unlikely, and it's usually activated by something else. Okay, so for the reasons we said, hyperglycemia results in excessive thirst, excessive urination, awakening to urinate, which goes with the excessive urination, blurred vision, we'll talk about why that is, sudden unexplained weight loss from losing the glucose in your urine and from breaking down muscle for gluconeogenesis, and headache. And okay, we have the excessive urination, remember, because we have glucose passing through our kidneys, causing this osmotic influx of water. So we have excessive urination, and then that causes excessive thirst. And then because we're not getting the glucose into the cells, it results in excessive hunger, poor wound healing because we don't have the tools or energy to heal our wounds, and also we're breaking down our protein for gluconeogenesis. And again, if we don't have energy, it's just going to lead to more infections. And we also get infections for other reasons that we're going to talk about: weakness, tiredness, weight loss, confusion. Okay, so here's kind of a review of everything we just talked about, but let's talk about it again. So why would we get polyuria? Because the glucose exceeds the renal threshold, the capacity is saturated, it goes through our kidneys, it brings in fluid because of the osmotic pressure. Is that right? Osmotic pressure? Yes. Okay. We also get polydipsia because all of this fluid loss leads to decreased oncotic pressure, and that basically sends a signal to our brain that we need to drink more water because we're losing so much water. Next, we have polyphagia because our cells aren't getting the glucose that it needs. Because they're not getting the glucose, our fat cells are being mobilized. We're producing ketone bodies to the liver for our brain, and our brain is saying, "Wait, what? I'm to the point where I'm relying on ketones. Let's get some glucose up in here. Let's stimulate hunger." So the person is basically starving, and they're eating, polyphagia. And then we may have weight loss, especially in type 1 diabetes, because we're just not getting enough glucose. We're excreting more glucose. We're mobilizing our fat so that we can get some energy, and this leads to decreased fat stores. Okay, now hyperglycemia can have more negative effects than even all of those listed. So it can, when we have too high of blood glucose, okay, when we have such high glucose in our extracellular fluid, and we have that we have poor glucose uptake. What happens is we just have poor circulation, and we also just don't have the energy that we need in order to heal our wounds. So I know when I was in the hospital, they would say, okay, if you have a blood glucose level over a certain amount, I think they said over 180 or over 150 or something like that, basically you are not going to be able to heal your wounds simply because we have too much glucose in our extracellular fluid and poor circulation. Also, our high circulating blood glucoses can lead to increased glucose in our lens of our eye because of the and this causes an osmotic gradient just like it does in our kidney. So because we have this glucose in our lens of our eye and the fluid coming in to kind of dilute it, then this can cause swelling in the lens and lead to vision disturbances. And this is one reason why we have vision disturbances in people who have diabetes. Also, we've talked about that the glycation of our cells, like when we have so much glucose, it can actually they can the proteins on our cells can become glycosylated, and it can really mess with how our chemical signals are conducted, and so that can lead to an impairment in how our chemical signals are received. And they can also lead to damaging of the blood vessels. That all this glycosylation, all this excess glucose can damage the blood vessels. And if we have damaged blood vessels, then we can't carry as much oxygen and nutrients to our nerves, and therefore we can have nerve damage. That's we see so commonly in diabetes. Okay, so diabetes, we know, can lead to chronic complications, retinopathy, nephropathy, neuropathy, peripheral vascular disease, and cerebral and cardiovascular disease. So the last data I have is from 2011 from the CDC, and it said that of those with diabetes who are at least 35 years old, about 22% reported heart disease, 9% reported cerebrovascular disease, and 16% some other heart disease or condition. Okay, so how does this work? Well, basically, we have so much glucose in our body that it just kind of tries to get on anything that it can. So when we're measuring hemoglobin A1C, what we're actually measuring is how glycosylated our cells are. And so how much glucose have they been exposed? We can measure by how glycosylated they are that how much glucose they've been exposed to over a long period of time. And that glucose, because it's in such high quantities, can actually be toxic and directly damages our blood vessels and other tissues. And because it damages them, what it results in is these free radicals, including nitric oxide, and just can really mess up our hormone levels and our platelet functions. So how is this expressed? Okay, it can be expressed both on our small blood vessels and our big blood vessels. So our microvascular diseases include our diabetic retinopathy. And this is kind of a symptom that we would see kind of further down the line for people who have had type 1 diabetes. I'm sorry, did I say kidney? Retinopathy is eye. Visual impairment. I'm sorry. But anyway, same thing. We see this as kind of a later term complication in type 1 diabetes, and it is the leading cause of blindness in adults. We have our nephropathy, which can lead to we have such high glucose that it leads to changes in the structure of the kidney. So the glomerular basement of the membrane actually thickens, and the kidney size increases, and it just doesn't work as well. We have decreased glomerular filtration rate. We're getting protein into our urine because our kidney is just not doing nearly as good of a job of filtering it out. So you can see in this little graphic here, we have our normal kidney here, and our urine is being filtered and it's going to go out and we'll excrete it. But here we have, when our kidney gets bigger, thickens because it's working so hard, then basically it's just not working as well, and we're going to put stress on our kidney, and the protein's going to leak out into our urine. Okay, we also see neuropathy, so that's pretty common that we would um, see foot disease, especially in people who have diabetes, or you'll even hear of an amputation in some cases, and that's because the chronic hyperglycemia is actually toxic to the nerves. So then it basically kills off the nerves, and we have decreased response to pressure, pain, temperature sensitivity. And now let's move on to our macrovascular diseases. So we can have peripheral vascular disease, which is pretty common and made worse by smoking. And because we are damaging these big blood vessels, it actually leads to impaired circulation. And because we don't have the oxygen and the nutrients that are being delivered by our major blood vessels, then we can this can lead to basically killing off of the tissue, and which can lead to a loss of limb or loss of mobility. And peripheral vascular disease can also lead to sexual dysfunction. So it's obviously a quality of life issue. Okay, we also can have cerebrovascular diseases. So diabetes can increase risk of stroke and dementia. Again, because we have just such high levels of glucose that it's actually toxic, but we can actually reduce risk for these complications through diet, just like we can reduce any risk of complications in diabetes through controlling our risk factors. And then probably the most common macrovascular disease from diabetes is cardiovascular disease. And again, our large blood vessels just become more and more diseased. Because of the pathology that we talked about earlier, we have higher lipid levels in our blood vessels along with higher glucose levels, and all of these can contribute to cardiovascular disease. Okay, so I'm trying to see what we haven't talked about here. Okay, I think this is all review for you. Okay, so I think we've gone through all of this, but let's just kind of look at this graphic. So we see that actions of insulin and glucagon, that if we have I think this is all review for you. I'm just going to go through it really quick. High blood sugar, we would promote insulin release. We would stimulate glucose uptake from the blood into the tissue. That would in turn lower blood glucose. If we have, and that would in turn lower blood glucose. If we had low blood sugar, it was promote glucagon. That would stimulate glycogen breakdown and raise blood glucose. So this is all a very simplified graphic, but hopefully it will help. Okay, so in general, what does insulin do? Okay, so that was kind of what we talked about, the insulin, what insulin will do for carbohydrates. What does insulin do for protein? Well, it increases protein synthesis, just so it's the same in line with everything that we've talked about. Insulin builds up, okay? So insulin causes protein synthesis. It decreases breaking down the amino acids to be used for gluconeogenesis. Makes sense, right? If we have insulin, we don't need to make new glucose. It's also going to stimulate the transport of branch chain amino acids to muscles and other cells. So think about it just like insulin helps our cells take up glucose, it's also going to help some of our other cells take up branch chain amino acids. And it promotes protein synthesis. We already said that. Okay, so we did talk some about the carbohydrate, but let's just put it here, list it all out here. So in carbohydrate, of course, we're going to increase our glucose storage. We're going to increase our glucose breakdown. Carbohydrates are going to activate our GLUT4 transporter. Do I have GLUT4? Okay. So we're going to talk more about GLUT4, but when you see a GLUT transporter, think back to when we talked about absorption. So we know a GLUT transporter brings glucose into a cell, and in this case, the GLUT4 transporter is actually going to increase glucose uptake from our muscle into our muscle cells and into our adipose cells. Insulin is going to break down glucose as well. So I know this can be a little confusing, but think about, okay, we have a lot of glucose and we have our insulin coming in saying blood glucose is too high, let's lower it. So we're going to store it, that makes sense, but we also are going to break it down and use it for energy. So both of those things can decrease blood glucose levels, both storing it and breaking it down. So insulin is going to promote glycogen storage, and it's also going to promote glycogen or glucose breakdown, so and promote glycolysis. As we would assume, we aren't going to have gluconeogenesis. It's going to decrease gluconeogenesis. We don't need to make new glucose. We've got enough glucose. Okay, so let's talk about GLUT4 just a little bit more. We again see it primarily in our muscle and in adipose tissue, and it's the only insulin-responsive GLUT transporter. And so what happens is this GLUT4 transporter is in, I believe it's in the cytosol of the cell, and when our body, when we have increased insulin levels, what actually happens is that the GLUT4 goes up to the surface of the cell and is there to let the glucose in. So as we would guess, if we have insulin resistance, then we have impaired GLUT4 translocation. So that's really part of the issue of why we can't get glucose into the cell when we have insulin resistance. We can stimulate GLUT4 through exercise, but that is not an insulin-dependent pathway. So if we look at some of these lifestyle issues, I guess you could say, or environmental factors that impact GLUT4, they really make sense. So fasting is going to decrease GLUT4. That makes sense. We don't need to bring as much glucose into the cell if we are fasting. If we have low insulin levels or diabetes, it's going to decrease it. But if we are carb refeeding, then of course that's going to increase our GLUT4 because we need to bring the glucose into the cell. If we treat it with we're treated with insulin, of course that's going to increase our GLUT4 availability and expression, I should say. So in all of these are kind of instances where our body is actually able to regulate the expression of this transporter depending on what type of circumstances our body is facing. And here's a graphic from your book from chapter 12. So here we have our GLUT4 gene. So this is in the fed state, right? And because I'm fed, I'm going to have insulin, and I'm going to increase my GLUT4 mRNA. I have all of these GLUT4 vesicles. My insulin is added, and my GLUT4 is going to go to the surface here, and then I can bring in my glucose into the cell. However, if I'm in a starved state, I'm not even going to make as much GLUT4. The GLUT4 might go to the cells once I get insulin, but it's not nearly so much, so I can't even bring in as much insulin. Or I'm sorry, I can't even bring in as much glucose. Okay, so we've talked about the effect of insulin on carbohydrate and protein. Now, what about on fat? Okay, so what happens is, again, just like any of the other macronutrients, it's going to increase storage. So if I have insulin, I'm going to increase my triglyceride storage. And because I'm storing my triglycerides, I'm not needing to break them down for energy as much. And therefore, I'm not going to have that product of the ketone bodies that are a result of fatty acid breakdown. I'm also going to decrease lipolysis by inhibiting hormone-sensitive lipase. So what a lipase does is it breaks down your fat. Lipolysis is breaking down your fat. So if if my insulin is saying I've got plenty of nutrients available, I'm actually storing things, then we're not going to need to break down our fat for energy because our body knows that we've got plenty of glucose. Okay, and it's also going to promote glycerol synthesis from glucose. So if you think about it, it's just another way to use up glucose. I'm going to be able to take the glycerol portion from the glucose. If you remember, down to glycolysis, we have the glycerol 3 phosphate. So it's actually going to increase glycerol synthesis by increasing GLUT4 mediated glucose uptake. And remember that glycerol synthesis allows for production of other important molecules in our body, such as our NADPH for fatty acid synthesis. So this kind of makes sense, right? If I'm taking in a lot of glucose and my insulin is increasing, then I'm going to try to use the glucose for other substances. Yeah. And also, I'm going to be building, we'll talk more about this in our fat section, but I'm also going to be have this glycerol that I can use to build up more triglycerides. So if I eat way too much, there's actually a pathway by which I'm going to make more fat. All right, now let's talk about the effects of glucagon on our macronutrients. So for protein, glucagon again is saying, I do not have enough glucose, do something about this. So what it's going to actually promote is muscle breakdown or protein breakdown so that we can use some of those components for gluconeogenesis to make more glucose. That makes sense. What is the net effect of glucagon on carbohydrate? We know it's going to mobilize glycogen stores. And it's going to increase gluconeogenesis from other amino acids. And then how does glucagon impact fat metabolism? Well, it's going to help us. It's going to break it down. It's saying I do not have enough energy, so I need to break down my triglycerides. And what happens is a part of my one of the products of breaking down my triglycerides is ketones. So I'm going to have ketogenesis, the making of ketones. And then just to tie that into before, when I get super, super high levels of ketones, then I have ketoacidosis. You can have ketone levels without having ketoacidosis. Okay, so again, I hope this is review for you, but people can choose different types of insulin in order to control their diabetes. We have the rapid acting, which is active in the first few hours, the intermediate acting, which kicks in a couple of hours after injection and goes till 12 hours, and then we have the long acting, which goes over a 24-hour cycle. Okay, so then our last topic is going to be the glycemic index. So what the glycemic index is it tells you not only how many carbohydrates or how much glucose is in a food, but it tells you how the effect of that what the effect of that food is going to be on your blood sugar level. So we actually give a number to a certain amount of food, and it's going to tell us both the quantity of the glucose and how fast it's going to trigger an insulin response. So how this number is calculated is that we have a standard, which is usually pure sugar or white bread, pure glucose or white bread, 100 grams of it. And then we would measure the blood glucose after giving someone that, and then we would compare the rise in blood glucose to another food and give it a ranking based on that reference. Okay, so our low glycemic index foods are listed here. We can have fruits, whole grain bread, oatmeal, something like that. And then when we get to brown rice or quick oats, we have a bit higher glycemic index. And then, as you would assume, these foods such as white bread or a russet potato or a melon or something is going to increase our blood glucose really fast. So something like a whole grain, it might have a lot of glucose in it, but it's going to trigger a much less severe blood glucose response, so we'll have a lower glycemic index number. So athletes can use this glycemic index to their advantage. So they might choose their foods based on that. So if, say I'm an athlete, say I'm a cross-country runner or something like that, and I'm about to go for a long race, and I eat something like a white potato or something, well, I'm going to have energy pretty quick because I have a high glycemic index for that food. But then it's not desirable because it's just going to lead to this fast increase in energy and then a letdown. So they might not want to do that if they have like a longer term event, which is almost any sport. However, if they consume low glycemic index foods like a whole grain product, then um, the body is going to have a slower rise in blood glucose, and therefore it's going to it's going to deliver the glucose from the meal over a slower period of time, so that the athlete would have more sustained access to the blood glucose, and it can give you an energy burst even well after you have consumed the food. The glycemic index of food can be affected by the variety of the food. So even you could have even when you're talking about different kinds of bananas or different kinds of fruit. We mostly only have one kind of banana, but you know what I'm saying. The different kinds of fruit, or the ripeness of the fruit, or the processing of the food, or the preparation of the food, all of those different things can affect the glycemic index. So when we say, for instance, that like let me think of an example, melon, let's say melon has a glycemic index of X. Well, what about if it's less ripe or more ripe? What if it's a watermelon? What if it's a cantaloupe? What if I've blended it up in a smoothie? Something like that. We have to ask all of these questions. So glycemic index is really about the quality of the carbohydrate and not the quantity. How fast does this food contribute to a rise in blood glucose? And really, they will measure the air, so they will track this, how fast the blood glucose rises, and they usually test it multiple times, of course, so that they can get like as accurate of a number as possible. And then they measure the area under the curve as a percentage of the mean value for the reference food for the same subject. So when we're telling people what to eat, especially people with diabetes, glycemic index, kind of think of it as like a tool, and you have to have it with the right client, because the information and the diet changes that come with diabetes can be really overwhelming for some people. So if we have like kind of an advanced client that wants to get even stricter control over their diabetes, this is kind of when we can introduce the glycemic index and say, okay, well, actually, depending on the foods that you have, it's not only the total grams of glucose, but how fast they affect your blood glucose. And again, another issue that would affect the glycemic index is what you're eating with it. So, for instance, if I'm eating cottage cheese with that watermelon, of course, that's going to lead to a slower rise in my blood glucose level. And so one of our most commonly consumed carbohydrate foods is rice, and that can actually have a large variability in the glycemic index depending on what kind of rice it is. So while brown rice has a low glycemic index, white rice has a high glycemic index. And here's a list of the ratings from lowest to highest glycemic index. And you can see that the ones that have, this is kind of interesting, the lowest glycemic index also have the highest amylose. So remember that the amylose is just that one string, and we get much slower release of glucose because we're just releasing it from one string. Whereas if we have a starch that has low amylose and high amylopectin, then we can actually release that glucose much faster because of all of the branches. So that's kind of another factor that can impact glycemic index. And here are our practice questions from this. There's one more thing I want to say. So glycemic index is how fast the blood glucose rises from a food. But we also have another measurement that we call glycemic load. And what glycemic load is it's a combination of the glycemic index and the total quantity of glucose in the food. So it's basically quantity plus how fast it gets released into the bloodstream. So that's glycemic load. So glycemic index is really just the impact on the bloodstream of the specific type of food. So here are your practice questions, and I have, of course, available for any questions that you may have. And I hope you have a good week.